A traveler returning home from a business trip, a pregnant woman living in a tropical region, both experience sudden chills, aching muscles, and a spiking fever. Inside their bloodstreams, a microscopic parasite is rapidly multiplying inside red blood cells until the cell wall violently ruptures. This exponential replication is the signature of Plasmodium falciparum, an organism that overwhelms the human body by doubling its numbers in the blood every few days. The first line of defense is keeping the parasite out entirely. This relies on environmental interventions like insecticide-treated bed nets and targeted chemical spraying on the interior walls of homes to eliminate the Anopheles mosquito that carries the infection. For high-risk individuals, doctors deploy internal chemical shields. Expecting mothers receive specific doses of antimalarials, known as intermittent preventative treatment in pregnancy, while travelers take strict regimens of chemoprophylaxis weeks before they even board a plane. But assuming these preventative measures offer complete immunity is a fatal mistake. The parasite is a living organism, actively evolving to bypass the chemical barriers we place in its path. For decades, chloroquine was a highly effective prophylactic. Then the parasite mutated. Chloroquine-resistant strains swept across the globe, rendering the standard defense useless in nearly every country where the infection is endemic. This forces public health officials into a continuous arms race. Today, a traveler's required drug regimen, whether that's mefloquine or atovaquone preguano, is dictated entirely by the specific, localized mutations of the parasite in the exact region they plan to visit. Maintaining this kind of mass prophylaxis strategy on a global scale is remarkably difficult. These powerful medications carry strict safety profiles, potential toxicities, and require rigorous patient compliance over long periods to remain effective. A perfect chemical shield for the entire population is impossible. When prophylaxis fails or is missed, survival depends on pivoting immediately from prevention to early, targeted, and verified clinical treatment. Relying on unverified home remedies or waiting to see if symptoms improve on their own allows the parasite to multiply unchecked. When symptoms start, seeking an immediate medical diagnosis is the only way to stop the infection from escalating. The window for action is terrifyingly brief. Uncomplicated symptoms can spiral into life-threatening multi-organ failure in a matter of hours. The escalation often begins in the brain. During its life cycle inside the red blood cell, the parasite exports specialized adhesion proteins to the cell's surface, physically transforming the red blood cell's membrane. These proteins act like glue. Infected red blood cells anchor to the brain's capillary walls, creating a physical barricade. This obstruction starves the brain of oxygen. Localized hypoxia triggers swelling, seizures, and coma, the defining features of cerebral malaria. While the brain swells, a second complication accelerates in the background: severe hypoglycemia, often referred to as the disease's silent killer. Blood sugar plummets from a massive dual drain on the body's resources. The billions of multiplying parasites consume the host's glucose at an extreme rate, while the systemic infection actively cripples the liver's ability to produce more. This is a mechanical, exponential, and systemic collapse. Waiting for symptoms to improve guarantees massive cellular destruction. To stop this biological cascade in remote areas, healthcare workers deploy pre-referral rectal artesunate. Administered to young children, it rapidly freezes parasite replication, buying the patient critical hours to survive the journey to a fully equipped hospital. For patients reaching a hospital, the standard of care is immediate, aggressive administration of intravenous artesunate. IV artesunate works rapidly, chemically dismantling sequestered parasites and clearing the massive infection from the bloodstream before hypoxia causes permanent neurological deficits or kidney failure. Surviving severe malaria requires a highly coordinated, resource-heavy medical counterattack executed within a razor-thin margin of time. That medical counterattack must be heavily tailored. For the pregnant patient, natural immunity drops. The parasite exploits this, binding uniquely to the placenta. The stakes are incredibly high, risking severe maternal anemia and premature birth. Clinicians must carefully thread the needle, selecting only specific antimalarial combinations that are highly effective against the parasite while remaining demonstrably safe for the fetus. For the returning traveler, their lack of natural immunity means they face a massive risk of rapid deterioration. Any fever occurring after a trip to an endemic region must automatically trigger a severe medical emergency protocol. The patient must explicitly state their travel history to doctors, who may not routinely see tropical diseases, and demand a rapid diagnostic blood smear to confirm the presence and species of the parasite within 2 hours. Eradicating the infection is an intricate matrix of decisions dictated by geography, parasite species, and the unique physiological vulnerabilities of the host. Outpacing malaria in the modern era demands striking a precise balance. We use localized preventative shields to hold the line where we can. But when the parasite inevitably breaches the gates, it requires aggressive, evidence-based clinical treatment to finally win the war.